Hello, I'm Dr. Ahmadu Usman Nahiru from the Department of Human Anatomy, Faculty of Basic Medical Sciences, Ahmadu Bello University, Zaria. In furtherance of our instructions in the development of the human embryo, today we will talk on the development of the gastrointestinal tract. And as a recap of what we had done previously, we had discussed the lateral folding of the trilaminar germ disc to create a tube that has 3 layers. The inner aspect of the tube is the endoderm. And if you remember, the trilaminar germ disc has at the lower aspect or at the inferior aspect, we now have the endoderm. In the middle, we have the mesoderm, and at the top, we have the ectoderm. Now, when it folds, the ectoderm will continue to be on the outside to form the future skin, and the mesoderm will be in the middle, and the endoderm will be on the inside. It is the endoderm that eventually forms the respiratory tract as well as the gastrointestinal tract and the urinary bladder. Now, our focus for today is the development of the gastrointestinal tract. Having formed the tube that we refer to as the gastrointestinal tract, we need to remember that the tract is divided into 3 parts. The first part, which is the upper part, is called the foregut. The middle portion is called the midgut, and the lower portion is called the hindgut. The foregut forms the stomach, the esophagus first, then the stomach, and followed by the upper 1/2 or the proximal 1/2 of the duodenum. The midgut starts where the foregut ends at the middle of the duodenum, so that the distal half of the duodenum is formed by the midgut. The whole of the small intestine, jejunum, ileum, is formed by the midgut. The cecum, the appendix, the ascending colon, and the right 2/3 of the transverse colon is all formed by the midgut. The hindgut forms the left 1/3 of the transverse colon, the descending colon, and the sigmoid colon, as well as the rectum and the anal canal. Each of the parts of the gut has its own vascular blood supply that is derived from the abdominal aorta. The vascular supply for the foregut is by the celiac trunk. The vascular supply for the midgut is the superior mesenteric artery, while the inferior mesenteric artery supplies the hindgut. Now, as this tube is formed, there are differential growths of each region of the gastrointestinal tract, so that eventually you now have these organs to be formed. The differential growth ensures that the stomach is formed by the dilatation of the distal aspect of the esophagus, so that the bend that emanates from the distal aspect of the stomach forms the beginning of the duodenum. As these events are continuing, forgive my voice, as these events are happening, the length of the gastrointestinal tract increases, so much so that not much of it can be accommodated within the abdominal cavity. So a lot of it has to eviscerate, meaning it has to herniate. In other words, it has to be moved out of the abdomen to be lying inside the extra abdominal part. And the midgut continues to be attached to the yolk sac via the vitello-intestinal duct. Now, when this happens, the herniation occurs at the 5th week of intraembryonic life. With further development, at 10th week of intraembryonic life, there is now gradual return of the gut into the abdomen, with the coils of the small intestine going in first, and the last to enter are the cecum, the future cecum, the vermiform appendix, and the ascending colon. They are the last to return. We should also remember that the differential growth and the high proliferation of cells ensures that even though initially we have a canal that forms the tube, at later times the whole of the canal becomes obliterated because of the dense population of cells, so that it will be only later that the gut gets recanalized. This has an implication on congenital abnormalities of the gut, which we shall see at a later time. By the time the gastrointestinal tract is developing, there is also a rotation, so that the anterior aspect of the stomach now comes to lie on the, so that the left side of the stomach now comes to lie anteriorly, and the right side of the stomach now comes to lie posteriorly. Now, if you remember, we have mentioned that the mesentery is attached to the whole of the gastrointestinal tract from the beginning to the end. And the name of the mesentery depends on which region of the gastrointestinal tract it is attached to. Now, the mesentery that is attached to the stomach is called mesogastrium, while the mesentery that is attached to the intestines is mesentery. Now, the mesentery that is attached to the colon is called mesocolon. And depending on whether we are dealing with transverse colon or ascending colon or descending colon or sigmoid colon, we will now be having transverse mesocolon, sigmoid mesocolon, or ascending mesocolon. Now, during the course of rotation, so that the left aspect of the stomach now comes to lie anteriorly, and the right aspect of the stomach comes to lie posteriorly, the lesser sac now gets deformed, so that the mesentery that is attaching the lesser curvature of the stomach to the liver is now referred to the lesser omentum. It is in the free edge of the lesser omentum that the hepatic artery, the common bile duct, and the portal vein lie, so that they can now be held with between the first and the second fingers, and you now have the anterior boundary of the epiploic foramen that gives access to the posterior aspect of the stomach to reach the lesser sac. Now, the mesentery that is drooping from the greater curvature of the stomach in front of the transverse colon, we will always refer to it as the greater omentum. But of note, we will see is that there is plastering because of this rotation. There is plastering of the duodenum to the posterior abdominal wall, and merger of the mesentery of the duodenum with the mesentery of the posterior abdominal wall. This makes the duodenum to become retroperitoneal. And this plastering and merger of the mesentery of the duodenum and the peritoneum of the posterior abdominal wall is called zygosis. Zygosis also occurs at the level of the ascending colon and the descending colon. However, the cecum is always intraperitoneal, except in rare occasions in which it is also retroperitoneal. That is a variant of the happenings. By way of looking at the implication of the rotations and the herniation of the gastrointestinal tract during development, when there is solidifying of the gastrointestinal tract, and there is failure to recanalize, there is atresia of that part of the gastrointestinal tract, such that if it is the intestines that did not canalize, we have atresia of that part of the intestine. And if it is the esophagus that did not recanalize, we will now have atresia of the esophagus. It should also be mentioned that during development, a diverticulum arises from the ventral aspect of the esophagus to form the future trachea and the lungs, so that future congenital malformations could be that of persistent communication between the esophagus and the trachea, the so-called tracheoesophageal fistula. Another congenital abnormality that needs to be mentioned is when the anus fails to recanalize, and then we now have imperforate anus as a congenital anomaly. We have not mentioned the development of the liver and the pancreas, but we will mention that in subsequent videos. In summary, we have mentioned that the gut tube develops from the endoderm that has the ends have fused together due to lateral folding of the triangular germ disc. There is also herniation of the developing gut. There is solidification of the developing gut and later recanalization, failure of which will lead to congenital abnormalities of atresia of that part of the gastrointestinal tract that has failed to recanalize. We have also mentioned that this recanalization may be interrupted by some other agents. There is need also to mention at this juncture that in the event that not all of the gastrointestinal tract returns, there is herniation or evisceration of that part of the gastrointestinal tract that has not entered back into the abdomen, which in itself is another congenital abnormality. Thank you very much.